Yeah, so
it's mostly for.
Well, it's mostly for like records and things
yeah.
like that. But you know, it's I post these videos to my public site, so I try to just. There are a couple of times where I have a couple students like and they're cool with it and we're demonstrating stuff. But generally, I like it just to be.
He doesn't want nobody to take his spotlight.
Yeah. Well, no. The thing about YouTube is the comment sections can get really interesting. And yeah, people are gonna. They're. It's just the way it is. People can be pretty cruel and
Colorful.
Yeah, colorful. Yeah. It's brave new world, right? That's what happens though. You get anonymous, right? You get anonymous on the internet, and there's kind of almost a dehumanizing quality to it, where maybe I think people don't realize that there's a human being on the other end, and can get pretty nasty. Okay, so we talked about that. Let's talk about arterial resistance. What do I mean by arterial resistance? What's going on there? Potentially.
Where you have the walls, the surface of the arteries. And
Now, what is resistance? What is resistance?
Futile.
What?
Futile.
Oh. Oh, I get it.
Nerd, sorry.
I didn't even hear that.
Okay. Wow. All right.
It could be like the size of the vessel.
Drag.
This is EMS, not Dungeons and Dragons.
Can it be both?
No. No.
It's gonna be on YouTube, so maybe.
It's, what is it, energy working against?
Yeah, so basically resistance, and don't worry, we'll flesh this out a little bit in a little more detail in a pulmonary when we do some formulas. But basically resistance is something that resists, that prevents the flow from occurring, right? So there are basically two things that can cause your arterial resistance to increase, okay? Two things. The first thing is not particularly intuitive, but it's something known as viscosity. Okay? If your blood is more viscous, okay, higher viscosity equals higher or lower resistance. Higher resistance, right?
Higher.
So thicker substances.
Yeah, so viscosity in a certain sense is how thick your blood is, or how viscous it is, okay? And if you have very viscous blood, that blood is going to require more force. More force needs to act upon that blood to get it to move around, which means that if you have to put more force into moving it, there's resistance, right? There's increased resistance there. The major determinant of our viscosity is something known as the hematocrit. Have you guys ever heard of that term, hematocrit?
Yes.
What is hematocrit? Or the HCT, the hematocrit. What does that mean? Something to do with blood?
Yes.
Okay.
It's a certain level within your blood.
Axonal
Yeah.
volume.
Sort of. So let's draw a picture. Let's draw a picture here. So imagine that I've drawn a tube of blood from somebody, okay? I have a tube here. Grab my red thing here. All right. And I have a tube of blood, and let's say that this is a 10 milliliter vial of blood that I drew here. All right, so 10 milliliters. You guys cool so far?
Mm-hmm.
All right. All right, I'll put a little color in there. There you go. You guys good with that?
Mm-hmm.
All right. I actually had one of my students last year was colorblind, so he couldn't see me. So it didn't help him out very much. Speaking of colorblindness, have you seen the going on YouTube? There's in chroma. Oh, my wife and I sat down and watched some in chroma videos, and we were just bawling. I was just bawling my eyes out.
Oh, what is
I do
it?
that a lot.
Yeah, what is it? When people can't see colors or something?
Yeah, so what it is it's a new technology that's developed, and I can talk about it in a little more detail maybe a little later on. but it corrects in like something like 70-80% of people. It'll correct for color vision. And so there are these videos out where, you know, people in their 50s and 60s have never really seen robust colors before, and they'll put these glasses on, and they'll just start crying. And one guy,
So
like,
it's like the hearing ones.
Yeah, like
yeah, like just like those, you know, one guy, like, you know, he's looking at his kids and he saw the blue in their eyes and he's crying. I was crying, my wife was crying. It's good stuff. It's really, really good.
Sounds like a good time.
Yeah. Oh, it is. Okay, so going back here. So what I do is I'm going to take this blood, I'm going to put it into a centrifuge, and I'm going to spin it down. Okay, what's going to happen when I centrifuge it?
Everything's separate.
Okay, it's going to separate, and what's going to go to the bottom?
You have the
Most viscous material.
Well, heavier stuff, right? Heavier stuff's going to go to the bottom. Lighter stuff going to go to the top. So after I get done spinning it down, it's going to look something like this. All right, all my heavy stuff, which is pretty much my red blood cells, right? All my red blood cells are going to be down here at the bottom, like so. And then I'm going to have mostly plasma on top, right? And the plasma is not as heavy, quote unquote, okay? And let's say that I have 5 milliliters of that red stuff down here, okay, of mainly red blood cells, right? And I have 5 milliliters of plasma, okay?
That's your hematocrit.
My hematocrit is this packed stuff here, okay? And so if my total sample is 10, and 5 out of that 10 is pretty much red blood cells, we would say that the hematocrit is 50%. Does that make sense? That's what hematocrit is. And we know normal hematocrit is in the 40s, more or less, you know. So if my hematocrit gets very high, okay, that's going to make my blood more viscous. Okay, that is one major thing. And we see that in certain patients, right? For example, patients that are COPD patients, a chronic obstructive pulmonary disease. They develop something known as polycythemia, right? Their body makes more red blood cells in response to them being chronically hypoxic. We can see this occasionally at higher altitudes as well, and we can see this in just blood disorders like polycythemia vera is one such blood disorder, but we'll talk about those in more detail in the medical blocks. Another thing that can do this, okay, is if I have somehow increased levels of proteins in my blood, okay? I have lots of proteins increase, or maybe I have a really massive increase in lipids or something kind of bizarre like that. So that's one part of it, viscosity. The other part of it simply comes down to the radius of my blood vessels. Okay? You guys are okay with radius, right? What is radius? So if I take a cross section of a blood vessel, what is the radius?
It's from the middle out.
Yeah, so radius is from the middle out. It's a chord that goes from the middle to the outer part. That's R. And then all the way through is diameter, right? So this is radius. Okay? Now, as my radius increases, what happens to my resistance? Resistance decreases. You guys cool with that? As the radius decreases, what happens to the resistance? It increases. You guys cool with that? Okay? And the resistance increases and decreases basically, okay, it's basically R to the 4th power. Okay, R to the 4th power. Okay, so it's not a linear relationship, it is, what kind of relationship? If it's to the 4th power, we're talking exponential, right? So very small, so basically the take-home point is very small changes in radius equate to very large changes in resistance. Does that make sense? Okay. Now, in the case of cardiovascular disease, where I perhaps have somebody that has significant arterial sclerosis, and we talked about that, and significant atherosclerosis, which we've talked about last week in ACLS. Okay, what might that do to the radius? Significant arterial and atherosclerosis. Decrease. What's that going to do to the resistance?
Increase.
It's going to increase the resistance, right? Okay. There's going to be more resistance to blood flow, which means what's going to happen to get blood to go through those vessels? The heart, right, is going to have to work a hell of a lot harder, right? Does that make sense? Okay. And there's actually a law, there's a physical law that relates these, and it's something known as Poiseuille's law. Any firefighters in here? Right? What? You talking about Poiseuille's law as a firefighter?
I'll
Okay.
tell you the name of the law.
Okay. Yeah. And that's basically that's a quantitative framework that we can use, but we don't really need to go into it in any real deep, specific detail here. Okay, you guys good so far? So far, so good? Okay, so just a couple more things that I want to talk about. I want to talk about taking your average pressure. So when I take your blood pressure, okay, basically what I'm doing is I'm checking your blood pressure when your ventricle is at rest, and that is called the diastolic blood pressure. Okay, lower. And then I'm looking at a pressure when your ventricle is at systole, which is called your systolic blood pressure. You guys cool with that? Okay. What if there was some way that I could just look at what's the average pressure, okay? What is the average pressure in the circulatory system, in the arterial system specifically, at any given time? Okay, is there just a way of kind of cutting through the nuance and kind of averaging it out a little bit? Because what does mean mean? Average. Well, that's one meaning of mean is average. All right, pithy, right? A little pithy use of language there. Yeah. Well, there are actually 3 different types of average, right?
Yeah.
Anyone take statistics?
Yeah.
Right? Mean, median, and mode. All different types. So mean is literally, average literally means central tendency, but we're just going to say that in this case it means mean. I'm going to say mean again. Okay. So, the mean arterial pressure is basically, it is a way of averaging the systolic and diastolic out, right? Is this anything that we can really do though out in the field? Does this have any practical application? What do you guys think?
No.
You'd be wrong.
Okay.
I was just leading you on with the look on your face.
Good job.
It's actually very important. Very important concept, and it's very easy to do. And it's one of the formulas you have to memorize. And it's one of the 2 major formulas that we talk about in cardiology. So everyone's good with cardiac output? Here's the next formula, and ding, 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 you should have learned this as intermediates. Even basics now, or EMTs are learning this. So, mean arterial pressure, it's average, right? So how do I average? Well, let's say that I get a 50% on my block exam in cardiology. I get an 80% in respiratory and a 98% in Med 1. I want to know what my mean grade is. What do I do?
Add them together and divide by 3.
I add these things up and I divide by what?
3.
Yeah, so I take the sum, right? That's sigma. I take the sum of all these guys, all right? And I divide by what?
3.
The total number of them are in, right? That gives me my average. So if I add 50 plus 80 plus 98, what do I get? 228?
Yeah, 228. Yeah.
So 228, and then I divide that by what? What does that give you? It's okay, use it. 76. Oh. I guess I'm not going to be listening to the Beatles today because I didn't make the grade.
Nice guy.
Yeah. There you go. Right. Outdated cultural reference there. Guy didn't make the grade. Okay. So let's now take this concept of taking a mean and apply it to blood pressure. So I need to know how much to weigh each. I need to know how much to weigh my systolic and weigh my diastolic, right? So what do we know? Well, let's talk about it. How much of my time do I spend in systole versus diastole? Is it the same?
More in.
Ventricles are bigger, so probably.
Well, here. Let's not guess. Let's just kind of gestalt things out a little bit and see if we can figure this out. I like to take these little journeys because it really helps us think outside the box. Well, let's look at the EKG, PQRST, and let's just make the assumption that we have a perfectly normal heart, and the PQRST perfectly corresponds to a beating heart. Okay. You can forget all that crap I told you about it not necessarily corresponding. Okay, let's just assume for the moment that things are working okay. Well, let me draw you guys a picture down here. Let's figure this out. Okay, so I've got a P, a Q, R, S, and a T. Okay? All right, guys. So, let me ask you a question here. Where is systole here?
The QRS.
So the QRS is all systole. Would you guys agree? So that's systole. Where is diastole? Okay, so the T. Anywhere else? Anywhere else? What's happening during the P wave? What's going on? Atrial depolarization. What's going on in diastole or systole? What's going on in systole? What goes on in systole? The ventricles contract, right? We got that covered, right?
So also in the QRS. is
Oh,
diastole.
yeah! Also, the P to R interval, I have diastole. You guys cool with that? Does that make sense?
Mm-hmm.
The ventricles are at rest during diastole, or during the P to R interval, and they're at rest during the T wave as well, right? The only time they're not at rest is during systole. Now let's gestalt this. Let's just kind of gestalt it. How many parts do we have here? 3 parts, right? How many parts of the 3 total parts am I in diastole? 2. What about systole? 1.
We've got a hidden.
No, I don't have anything hidden. We've accounted for everything, right? So would you guys take that trip with me? Would you buy that ticket if I told you that you spend 1 part of your time in systole and 2 parts of your time in diastole, and there are a total of 3 parts? Would you guys buy that ticket seeing just, kind of, again, we didn't get real exact, but more or less, can you guys see that relationship here?
Yes.
Can you more or less see that I'm going to spend more time in diastole than systole? Okay, about twice the amount of time in diastole than systole. You guys cool with that? And that hopefully makes sense because it takes time to fill the ventricles, right? Because generally speaking, is ventricular filling an active or a passive process?
No.
It's pretty passive, right? Do the atria have a whole lot of muscle? Do they do a whole lot of contracting? Not so much. okay? There's not as much muscle there, so I need that time. It's more passive. So, to construct my equation, I know that it's going to equal, okay? Well, I know that I'm going to have to add my systolic and diastolic up, right? Because I'm doing an addition here. You guys cool with that? Basically, systolic is one test, and diastolic is another. Systolic is cardiology, diastolic is respiratory. But airway is more important than circulation, let's say, right? However you want to look at it. So we're going to spend more time on that, right? Okay, so instead of these all having equal, right, in this case, these are all have equal value, right? Here, it's a little unequal. So when I add these things up, okay, so it's systolic. It's 1 times the systolic, right? Because you guys all agreed we spend 1 part of the 3 total parts in systole. 1 times systolic. Okay, plus, right? Now I need to add my next test, diastole. 2 times diastole. All right, and is that it?
Divided by 3.
Divided by the total number of parts that I'm dealing with. How many total parts are we dealing with here? 3. You guys cool with that? Divided by 3. And let's go ahead and just simplify this equation a little bit. Mean arterial pressure equals systolic, because what's 1 times anything?
It's someone.
Anything.
No,
Whatever.
whatever it was.
Yeah, right?
1x
Okay,
is
systolic plus 2 times the diastolic, right? We spend twice the amount of time, divided by the total amount of time, 3. And that is our mean arterial pressure formula. So let's just do it. So I have 120 over 80. Woo, perfect blood pressure there. So let's plug that in my formula. So MAP equals 120, right? Plus what? 160, right? That's 2 times my diastolic divided by 3. What's 120 plus 160?
280.
280, right? Divided by 3 equals 93, and I think some change, right?
3.
0.3, yeah. 93 millimeters of mercury. Are you guys cool with how I did that? All right? That's how we did it. Normal mean arterial pressure is about 70 to 100 or so, okay? About 70 to 100 in an adult patient. Significantly less than 70 indicates a problem, and significantly higher than 100 might indicate a problem. And we'll get into the little more nuance of that, but right now this is just kind of foundational stuff. Okay, you guys cool so far?
Sure thing.
You good with mean arterial pressure, with cardiac output, Starling's law? We talked about the basic anatomy and physiology. Let's real briefly, since I didn't talk about it earlier, let's real briefly talk about the coronary arteries. You talked about these with Paul, right? Sort of, yes. What are the major coronary arteries? Okay, so I have my major. Where do they come off of? Where do my coronary arteries come out? Where do they start?
Off of the
Base.
atrium.
near the
Aortic arch.
There you go. So I have my aortic arch, right? And I'll just draw that here. All right. So right here is my what valve? That's my aortic valve. All right. Right at the base of the aortic valve here, at the root of the arch, I have my major coronary vessels. Okay. I have one that comes off the left side, which is known as the
Left coronary
the LCA, and then one that comes off the right side, known as the
right.
RCA. Cool. The RCA primarily supplies which side of the heart?
Right.
Right, cool. Don't make it more difficult than it needs to be, okay. So the RCA supplies the right side of the heart, okay? And it eventually comes down and becomes the posterior descending artery a little later on. And you, of course, you have your little your branching marginals. We're not going to talk about those in detail. So the RCA primarily supplies the right side of the heart, okay? What areas of the heart specifically are we talking about here?
Right atrium.
Okay, so we're talking primarily the right atrium up here, the right ventricle, and I wish I had a heart model.
Yes, amen.
Huh? Yeah, the SA node, definitely. SA node in the right atrium there, definitely. But if maybe I'll try to draw the heart here and, okay. And I'll draw just a little bit of the internal structure. All right. So the right coronary artery primarily supplies this area right here. Would you guys agree? All right. So we got the right atrium, which includes the SA node, right? And we know that blockage of the right coronary artery commonly causes bradycardia due to compromise of the SA node. You guys cool with that? And we talked about that already when I lectured on heart blocks, so I won't belabor that point. Obviously, the right ventricle. Does any part of the left ventricle get supplied by the right coronary artery?
It can.
Yes. What part of the left ventricle gets supplied?
I don't remember.
Okay. What on the 12 lead? What tells me that I might have something going on with the right coronary artery on the 12 lead?
You do an inferior, a right side lead?
Maybe, but what lead? What am I looking at? What 3 leads do I look at when I'm looking at the right coronary artery primarily?
Maybe 5 to 6.
Anybody? This is 12 lead 101 here, guys.
3 ADF?
Yeah, there you go. 2, right? 2, 3, A, V, F. And if I see ST elevation in 2, 3, and A, V, F, that makes me potentially think of what? What kind of MI?
Inferior.
You guys remember the term inferior, right?
Mm-hmm.
Well, when I say I'm having an inferior STEMI, am I talking about the right atrium? Am I talking about the right ventricle? Since when has the right ventricle ever been called the inferior wall?
It's higher than right side on
Yeah. When I say that somebody's having an inferior wall STEMI, what we're really talking about is the inferior wall of the left ventricle. That's why it's called an inferior wall STEMI. But we know that a significant percentage of the time, if you're having an inferior wall STEMI, you're hitting the inferior wall of the left ventricle, you also might be hitting these other structures, right? The right atrium, the right ventricle. Does that make sense? But they don't specifically say that in the name of the STEMI. You have to infer that because you have to understand the coronary circulation and what areas of the heart are perfused by that coronary artery. Are you guys okay with that? Does that make sense? So the right coronary artery does supply part of the left ventricle, but just a small part of the inferior wall of the left ventricle, okay? So it's not a huge part of the left ventricle, but it does supply a little bit of the left ventricle. Are you guys okay with that? Is it, are you okay? Okay. So now let's move on over to the left coronary artery. The left coronary artery doesn't last very long, and because it becomes what?
The circumflex.
Yeah, so it actually becomes 2 things. It becomes what?
Circumflex the descending artery.
So the circ kind of goes around the side, right? And then I have
So anterior
the
descending.
LAD, right? Right, so the LCA bifurcates and it becomes the LAD, the left anterior descending, and the circumflex. Alright? The circumflex supplies what part of the left ventricle? Because this is the LV here, right? So what part of the left ventricle is over here on the side? Lateral, right? That's lateral means side. The lateral wall of the left ventricle. You guys cool with that?
Mm-hmm.
Okay. What leads are we looking at when we look at the circumflex artery?
5 and 6.
Okay, so V5, V6, that's not the end of the story though.
Yeah, 1 and 8.
Yeah, 1 and augmented vector left. You guys cool with that?
Mm-hmm.
Okay, good. Now, the LAD supplies the biggest part of the left ventricle, known as the, so right here on the front of the heart here, the anterior wall, right? The anterior wall. And the anterior wall is right, basically right down here, right? You guys cool with that? That is the biggest portion of the left ventricle. Okay. So the anterior wall of the left ventricle, and what leads do we look at there? V3 and V4, and that just leaves us with kind of this little area right in here, which is the septum, right? The intraventricular septum, or the septal wall. And what leads do we look at there? V1 and V2, right? So the inferior wall of the left ventricle, to include the right atrium, right ventricle, SA nodes, possibly part of the AV junction. Okay, that's all the right coronary artery, 2-3 AVF. You guys cool with that? Okay. Moving over to the left coronary artery, the circumflex. Okay, primarily the lateral wall of the left ventricle, V5, V6, 1, and AVL, right? The septal wall is the left anterior descending branch of the LCA, right? V1 and V2, and then the anterior wall of the left ventricle, which is the significant part of the muscle. You're looking at V3 and V4. You guys okay with that?
Yes.
Make sense?
Mm-hmm.
Good to go? All right, so going back to these coronary arteries. When do these coronary arteries receive most of their perfusion?
When the left ventricle contracts.
Okay, so when the left ventricle contracts, what happens? Through what? The aortic valve. What does the aortic valve do?
It opens up.
Okay, so it opens up like this. I'm going to draw the leaflets of the valve opening up. You guys cool with that?
Yeah.
And then blood gets pushed through that valve into the aortic arch. You guys cool with that? Do you notice anything queer about this, though?
They're kind of blocked.
Say it again.
They're kind of blocked.
Yeah. During systole, the aortic valve is open, and those leaflets are covering the coronary arteries, which means what? Which means that the blood flow is going to be kind of limited. But what happens during diastole?
The leaflets close.
Okay, yeah, the leaflets close, the valve shuts, and then blood can backflow through the coronary arteries. So believe it or not, a significant part of your coronary perfusion occurs during when? Diastole. Does that make sense? And this is yet another problem when it comes to really fast heart rates. Is not only am I impairing ventricular filling times, but I might possibly be impairing the amount of time that I spend perfusing the coronary arteries as well. So it's kind of a double whammy when I get these really, really fast heart rates. Does that kind of make sense there? You guys cool with that? All right. So those are your coronary arteries. You can also have a posterior wall infarction as well, right? And the posterior wall infarction might be due to blockages of either the right or the circumflex. And that just kind of depends on what's going on there. You guys good with that? Okay. Excellent. All right. Let's see where we talked about that. Let me just make sure I'm covering things. Yeah, there's a whole, I actually took notes and I was going to do a whole bunch of math stuff, and I was actually going to talk about flow and using derivatives to get the flow. I don't think you guys need any of that right now, do you? I don't think you do, and it's not going to be on the National Registry exam. So, what's that?
So you can't even add and subtract, right?
Yeah. So, we'll keep it basic, and at this point, I've covered the critical material that you need. Okay, the critical concepts have been covered, so we don't necessarily need the gravy on the stuffing at this point to kind of proceed into the rest of cardiology. Are you guys okay so far with the basic anatomy and physiology? Makes sense? Okay. I would ask that you guys please read through the chapter though. I'm gonna now kind of take a turn, and I'm gonna start talking about specific disorders now. And knowing about the specific disorders and knowing how to assess them and treat them and manage them really depends on you guys having that foundation. And all I can hope to do is maybe, best case scenario, I can cover 75% of what's in your book, okay? I might be able to do that in class. There's going to be little concepts and words and things like that that I may not just get to, okay? So please take your reading and study time seriously. I would ask, please do that. And please bring questions to me if you're going through the reading and there's something that doesn't make sense or something that possibly maybe seems to contradict what I've talked about. You need to bring those when you come to class to me, and then we can discuss them. That way stuff isn't falling through the cracks. You guys okay with that? The registry exam, when you guys finally get to it next year, it's kind of a robust test, and there's a lot of stuff on there. Even the skills exam has changed in the last few years. Even since you remember, Lorenzo, they are now doing full-on 12-lead analysis in static cardiology, which is something that we haven't typically seen, which just adds that much more dimensionality to what you guys have to do. Okay, let's see here. Let me make sure that I am not... you know what? Before I put you guys on another break, there's just some language that I want to cover to make sure we're okay. Have you guys noticed yet? I know we're still pretty early in paramedic school, but have you noticed that medicine tends to take a simple thing and make it complicated, right? A simple thing like heart rate, and then they say, oh no, it's not heart rate, it's chronotropy, right? They tend to take a simple concept and make it linguistically pretentious, we'll say. So I want to make sure that we all can speak that pretentious language, and there are some terms that I want to make sure that I don't miss here. Okay. Let's talk about defibrillation and cardioversion. You guys will be doing more of that in your labs this afternoon. This is going to be really confusing, and I'm sorry. It's not my idea. It's not my fault. Okay, it is what it is, though. There is some alternative terminology that occasionally is used, and they love to use alternative terminology on tests. So, there is a word if you see this word, let me just throw it out and see what you guys think. If you see this word in your book, on an exam, on a quiz, or you hear somebody say this word, let's see if you know what it means. What if I were to say unsynchronized cardioversion? What would you guys think of me?
I would think you're not lining up your artery with your arteries.
Well, keep it simple. What is synchronized cardioversion?
You're syncing it on the
Okay, what was unsynchronized cardioversion?
rebound.
What is that, really? It's defibrillation, right? Does that make sense? Okay. So that's one of those words, right? That is a word, a phrase that may come up. And you've got to be able to do that, okay? It's really easy to make something more complicated than it really is. So when you're seeing these terms, you need to stop, take a deep breath, and go, okay, synchronized cardioversion. I know what that is. I hit the sync button, right? I go to defibrillate, but instead of defibrillating, I hit the sync button. Unsynchronized cardioversion, oh, the sync button's off. Oh, it's the same thing as defibrillation. Okay, makes sense. You guys good with that?
Yeah.
There are a couple of words, and we're going to talk about these in more detail in the medical block, particularly Med 1, when we go into neurology in a little more detail. But because stroke is a big part of cardiovascular disorders, you're going to see some stroke questions. So I want to make sure you guys are good on some basic terminology. So I have something called aphasia, dysphagia, and aphasia. There are three different words that sound similar that have very different meanings. So what is aphasia?
They can't speak at all.
Okay, so aphasia with an S is they cannot speak. Okay? Which means typically the speaking areas within the brain are damaged. Okay, we'll talk about these in more detail in neurology. We'll talk about Wernicke's and we'll talk about Broca's speech areas because they're two different things. One of them is for understanding language coming in, and then one of them is for getting the right language out. Okay, we'll talk about those in more detail, but in general, aphasia is you cannot speak because generally the centers in the brain that are involved in linguistic processing are damaged. You guys good with that? Mm-hmm. Now, what is dysphagia?
So it's like trouble swallowing, right?
Okay, dysphagia with an S again. Aphasia, dysphagia is difficulty speaking. Okay, so if I have dysphasia with an S, dysphagia with an S, okay, it is different than aphasia, okay? Because with dysphagia, the brain centers are working, but I can't get that information from the brain out, okay? So this is where like slurred speech comes into play, okay? Does that make sense? And then finally, I have aphasia with a G, not an S. Aphasia, G is inability or difficulty swallowing specifically. Okay, you guys good with that? Okay, you guys good with that? All right, and I want to just emphasize a couple points from ACLS last week. What is, and they kind of, in a roundabout way, answered this, but I just want to make sure everybody's on the same page. When dealing with what tends to kill people that are having acute coronary syndromes, what tends to kill them when in the period of time that you guys are taking care of them, what tends to be the most common thing that kills them? And you guys dealt with those all afternoon in your skills for the most part. Dysrhythmias, right? Lethal dysrhythmias tend to be what kill people having acute coronary syndromes. Okay, there are other things like cardiogenic shock and this and that, but in general, the most common thing that we run into is a lethal dysrhythmia, VTAC, VFib, that kind of thing. You guys okay with that? Okay. I wanted to talk real quickly And there are some things that I'll go into a lot more detail in our cardiology pharmacology day. Let's see, which pretty much all the rest of the things that I want to cover are going to be on that day. One thing I do want to just emphasize real quickly, and this was right out of your reading in ACLS, is the oxygen. And I know we talked about it in basic terms. We don't give oxygen to everybody, right? And there are certain thresholds that we shoot for, right? 94 to 99% or thereabouts. And if they're okay, if they're above 94 and they're not having any dyspnea, it's okay to withhold oxygen, right? Are there some risks associated, possible risks associated with really high levels of oxygen in patients? What are those risks? Yeah, we're going to get into that. The hypoxic drive is an interesting one. I'm going to talk about that in great detail in respiratory because it's a bunch of BS. Okay, it's a scarecrow that it's just a scarecrow that people keep propagating, and I've talked about this ad nauseum, and it's still even here in Las Cruces, it just tends to be this. Yeah. Okay. That aside, there are some other real things that we're concerned about. One of them, it potentially appears, okay, that higher than normal levels of oxygen may increase the risk of causing coronary arteries to spasm. And I say may, okay. Again, this is through the AHA and through some studies that they've done. It may cause spasm. So what might that do to the acute coronary syndrome? It might potentially make their pain a little worse, right? Giving them oxygen when they don't necessarily need it. So that is one thing to potentially worry about. Giving people oxygen that don't necessarily need oxygen. But there is a whole other discussion with oxygen when it comes to reactive oxygen species, free radicals, hypoxic vasoconstriction in the pulmonary and those kinds of things. But we'll get to those in pulmonary. We don't need to go there quite yet. Okay, so that's it. I think we've got the good foundation. I've covered all the foundational things I want to. I'll leave the rest up to you guys as far as self-studying and then coming to class with questions. And from here on out, we'll start talking about specific disorders and how to manage them. But let's get you guys on a break. I'll see you guys in about 10 minutes. We'll wrap things up before lunch, and I'll get you out of here for lunch.